Welcome to the ONC Health IT Certification Program Developer Roundtable. My name is Tom Deneen with Kaufman and Associates and will be assisting with the logistical support for this Zoom session. The materials contained in today's presentation are based on the provisions contained in 45 CFR Parts 170 and 171. While every effort has been made to ensure the accuracy of this restatement of those provisions, this presentation is not a legal document. The official program requirements are contained in the relevant laws and regulations. Please note that other federal, state, and local laws may also apply. This communication is produced and disseminated at U.S. taxpayer expense. You can ask questions by clicking the Q&A button, which is located towards the bottom part of your screen. Click on the Q&A bubble icon, and this will pull up the Q&A box, which will open to the right side of your Zoom interface. You may also use the raise hand function under reactions, and we will unmute your line to verbally ask questions during the session. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present or share information. If you need technical assistance during the session, please click the chat bubble icon at the bottom of your screen, and this will pull up the chat box, which will open to the right side of your Zoom interface. Please type the issue into the chat box, and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Rob Anthony.
Thanks. Good morning and afternoon, everybody, depending on where you have joined us from. This is our quarterly roundtable, and today's session is, as you can see from the agenda, going to be all about HTI-1 and some of the updates that we have made to some of the resources on certifications portion of ONC's website, such as our test procedures and CCGs. There is Q&A, so I welcome any questions from folks. We are happy to try and answer what we can, and if we are not able to get to your Q&A during the meeting, please do feel free to submit a question through our JIRA customer service inquiry system that you can also get to on healthit.gov. Let's go to the next slide. We're going to hear from a number of different folks, including Ashley Hain, who is the branch chief of our tools and testing branch within the certification and testing division, Jeff Smith, who is the deputy director of the certification and testing division. And if you have things that are required for HTI-1 compliance, Jeff probably had a good hand in writing most of that. And then Jim Youngkin from Audacious Inquiry, which is a contractor that ONC uses to maintain a number of our systems and resources, is going to go over some of the more recent changes of things that have been impacted by HTI-1. We always get the question whether the slides and the recordings will be available, and we will undoubtedly put this in the chat later. But just to let you know, yes, the slides and recording will be made available on the healthit.gov website. You can generally find them in the program resources area of the certification portion of ONC's healthit.gov website. And with that, next slide. I'm going to turn it over to Jeff Smith for the HTI-1 final rule overview.
All right. Thanks, Rob. Appreciate that. So yeah, I'm going to talk about a few of the high points related to HTI-1. Specifically, we're going to talk a little bit about the structural changes that we've made to the program, and then do a flyover of some important updates to US CDI, a new requirement related to patient-requested restrictions on the use of their data. And then we'll spend a little bit of time swimming around in the DSI and Insights condition waters before turning over to Ashley to talk about some of the updates that we've made on the ONC website and related resources. So if I could go to the next slide, please. Okay, so first a couple slides here on the structural changes we've made. So we've done away with the edition construct, which was actually retroactively added to the 2011 edition back in 2012 as part of the 2014 edition, if you can remember that far back. And we did this for a number of reasons, notably to make the program more flexible for users, that would be developers, as well as to communicate out to the users of certified health IT in a way that would more clearly delineate between which technology is certified versus not. The addition construct has been in some ways beneficial for developers in marketing a whole new product, but at the same time, it's caused some confusion for users, and we've been looking to try and address that for some time. This additionalist construct will also help our federal and HHS partners who are increasingly looking to leverage certification criteria or just standards that we've adopted for their own purposes. And, I think today, somewhere north of 15 or I think 18 different federal programs reference ONC certification in one way or another. And we think that number over time may grow. And this kind of consistent, this like always live list of certification criteria and adopted standards will help us do that. Now, to operationalize this, if you could go to the next slide, we had to essentially establish expiration dates for certification criteria and standards. And essentially what this means is a module that is certified to, and we'll use US CDI as a good example, today can be certified to US CDI version 3 starting now. And they will have until the end of next year, December 31st, 2025, in order to update and provide their customers with US CDI version 3 based technology. And essentially, again, this is kind of how we're operationalizing the program rather than having additions and having this kind of lump sum switchover between previous certification criteria and new addition certification criteria. Instead, now we have expiration dates in certification criteria and as well as in standards that underpin some of those criteria. Next slide, please. Okay, so just to put a spotlight on US CDI version 3, the United States Core Data for Interoperability. Again, this is going to be the standard of record. It is today, it's an option. If you want to get certified to US CDI version 3, you may do so starting today, starting now. But you'll have until January 1st of 2026 to make that transition from US CDI version 1 to version 3. And we've identified those certification criteria that if you have modules certified to, would be impacted. And you can see those there below. Notably, I would say transitions of care, view, download, transmit, and of course our standardized API for patient and population services. Okay, next slide, please. All right, here's kind of a visual of the new data elements that we've got in US CDI version 3. Again, consistent with what we've been messaging since the genesis of US CDI, this is a core set of data that we think are essential to support patient care and that we need to have consistently and reliably and available in a standardized format. And so you can see here, part of the yellow stars there has been an emphasis on health insurance information, as well as a few new vital signs, as well as a number of new demographic data elements and health status assessment data elements in US CDI version 3. And again, if you've been kind of following that work for any amount of time, you would know that this is really meant to support some of the health equity by design work and the need to ensure that certified technology can reliably and consistently exchange information that would be salient to health equity. All right, next slide. Okay, I mentioned a new functional requirement that we included as part of HTI 1 final rule, and that is the patient requested restrictions. This is something that we did not have as a standard-based requirement, so developers have flexibility to implement this in whatever way they think satisfies the basic functionality to enable a user to use an internet-based method to request a restriction on the use or disclosure of their data. And we know that this is an area of fairly intense interest. We got a lot of comments during the public comment period for this. And we know that there's a lot of there's a lot of activity in this space, standards-based activities, data segmentation for privacy being one standard. But also we know that there are other efforts underway to try and facilitate this HIPAA privacy rule right. And so we will continue to monitor this space, and certainly interested in folks who have experience either implementing or adopting data segmentation for privacy on the CDA side, but also we know that there's a FHIR-based implementation guide that is getting worked and reworked, and so would be happy to receive any information related to this general area of interest around data segmentation. All right, next slide, please. Okay, so now we've got a handful of slides going a bit deeper on decision support interventions, or DSIs, and we've got a handful of slides that we're going to go in a little bit deeper on the insights condition. So if you could go to the next slide, please. So we, about 3 years ago, started to look at the question, how can AI be used in healthcare? And around the same time, there was a really excellent graphic that the Government Accountability Office put together. They put a landscape analysis together to really start to answer this question. And I think it will be no surprise to this group and this crowd, but certainly there are a number of uses and applications across both the clinical and administrative or operational domains, where predictive technologies and AI or ML-driven technologies are being used to support decision-making. So as a part of this, if we could go to the next slide, as a part of this work, we also started to see some fairly clear and consistent themes in terms of some of the challenges to adoption. And that really does, I think, frame the way that we looked at this, which is to say, this technology can do great things. Why is it not being adopted wholesale and across the industry? What are the barriers to adoption? And what we started to see was that, well, there were some very good reasons that these kinds of technologies and innovations weren't being adopted at scale. And that's because peer-reviewed research, generally speaking, found that some of these algorithms and predictive models would amplify bias. They would magnify concerns related to privacy. They would reinforce common and non-evidence-based practices. They solidify inexplicable differences in health outcome, as well as perpetuate information asymmetries and generally lead to recommendations that were either ineffective or unsafe. And I think we did a fairly intensive overview of these issues across a series of blogs that published beginning in January 2022 and ended towards the very beginning of 2023. I think we did 5 blogs, a lot of really good, I think, and interesting reading there. Hopefully somewhat entertaining as a blog needs to be. But at any rate, if you go to the next slide. What we ended up developing over the course of our investigation was this concept of faves. And essentially, what we tried to articulate through this framework was, how do you describe what high quality means within the context of healthcare? And so when we looked across the literature, one of the things that we found, and I think makes sense, within the context of healthcare, high quality means that the algorithm or the model is fair, it's appropriate, it's valid, it's effective, and it's safe. And so this really became kind of the quality framework and the set of principles that we used to develop the policies in HTI-1 related to decision support interventions. Next slide, please. So here is the logic model that we produced in terms of trying to think about how can ONC use its authorities to make an impact on this space. So what we thought was, if we could bring more transparency to data that are used in DSIs, if we could bring transparency to the performance of algorithms, specifically predictive algorithms that are used in patient and clinical and administrative and operational environments, and if we can bring some transparency into the competencies of organizations that develop such predictive algorithms, then we can start to ensure better, more trustworthy, high-quality predictive DSIs are used And honestly, we could support the further development and growth of applications in this space, because we again come at this from the idea that these are important technologies that ought to be used. We have across the program, or across the certification criterion really, as well as with some additional programmatic requirements, steps to ensure transparency across these verticals. Next slide, please. So we did finalize a definition for predictive DSIs. It's really kind of a three-part definition, and it essentially, predictive DSI means that technology that supports decision-making based on algorithms or models that derive relationships from training data, and then produce an output that results in a prediction, classification, recommendation, evaluation, or analysis. And I'll note here that you don't see anything in here specific to machine learning. And in fact, we do talk at length in the proposed rule around what an algorithm is and what a model is. And it could be a simple statistic or linear regression type of arithmetic. So it's important not to think about only machine learning based approaches as being the cutoff point, because that's not part of it. Really, this is a three-part definition, and we do kind of go into the weeds on what all of this means in the final rule. So you want to check that out. The other thing that I'll note here is that we were purposefully broad in establishing a definition that did not tether itself or constrain itself by scope, or by use case, or by level of risk, or by the developer who developed this predictive DSI. We were purposefully broad, and the broad nature of the definition is only a piece of the puzzle. It's really, how do we apply the broad nature of the definition? And that is where kind of the rubber meets the road in terms of programmatic requirements. Next slide, please. So a quick programming note on some questions that we've already received from numerous interested parties. And that is a fairly basic question around, is my technology, or is the function that my software provides, a predictive DSI? And I think it's really important to note that we are not going to make that determination on your behalf. We've provided a definition for predictive DSI, and we have a host of content in the proposed and final rules focused on helping readers and interested parties make that determination for themselves. We've even included a list of examples and have tried to get fairly specific on when those examples don't meet the definition of a predictive DSI and why. But at any rate, I think it's incumbent on regulated industry and those of you that have certified certified technology to make that decision. We've provided some resources here. And again, as Rob mentioned, these slides will be available, so you can go directly to some of those links that we've got in this paragraph. But if you send us a question asking if a specific algorithm or if a specific technology meets the definition of a predictive DSI, this is likely going to be an answer that you'll receive. Okay, next slide. Okay, so again, just to kind of help folks through the question of when is a developer responsible for source attribute content and risk management practices, which are kind of the pieces of the puzzle we'll go through a little bit closer next. It's really, is the predictive DSI supplied by the certified health IT developer? And if the answer is yes, then source attribute information must be complete and up to date, and risk management practices must be applied to that predictive or those predictive DSIs. If the answer is no, a developer can still get certified and still should get certified to B11 if they want to remain compliant with the base EHR definition. But they don't have, they're not responsible for source attribute content if they don't supply any predictive DSIs. Now they are still responsible for providing the source attribute fields so that customers may be able to modify or change those fields. But they're not responsible for the content in those fields, and they're not responsible for applying any risk management practices because they don't supply any predictive DSIs. Okay, next slide, please. All right, so what is the concept of supplied? Well, supplied by the Health IT developer as part of its Health IT module means that the predictive DSI is that it's been authored or developed by the certified Health ID developer. Supplied also means that the predictive DSI could have been sold or marketed or otherwise explicitly included as part of a Health IT module. So if the developer issues a press release about how they're working with a third party, be that a health system client or with another tech firm, odds are pretty good that's considered supplied by. So essentially it means that the developer has taken on stewardship and accountability for that predictive DSI for the purposes of the Health IT module, and that knowledge of its use is known by the certified Health IT developer. So that's at a really high level. Again, there's more discussion around supplied by in the final rule. Next slide, please. Okay, so to try and help tease out a little bit of what we just went through in some fairly dry, in a fairly dry way, I thought we'd talk a little bit about an analogy here about everyone's favorite EHR, yours and mine, and that is the NES EHR. So let's suppose that NES EHR has a hypertension model that they have developed. Now this is their model that they've been working on for years, and they include it as part of their product. They supply it, and again, it's something that they've developed. Now let's consider that a new hypertension predictive model made by Zelda is out on the market. And NES EHR didn't develop this in-house, but they've worked with Zelda to predict or to produce this predictive model. If you click one more, I think we'll get to the takeaway here. Both the Zelda model and the developed model, the NES EHR developed predictive model, both of these would be considered supplied by. And both of these would be subject to ONC requirements, which means that for both of these predictive models, NES EHR would have to provide access to complete and up-to-date source attribute information, and intervention risk management practices would have to be applied to both of these predictive DSIs. Again, because one was developed by NES EHR and the other one was supplied by NES EHR in a very kind of public and knowing way. But let's consider kind of a third option here. And that is Konami's contraindications model. Now, Konami is made by a third party, but they've made it in a way that NES EHR can plug into. Now, in a situation like this, NES EHR isn't required to provide access to complete and up-to-date source attribute information that NES EHR is responsible for. In fact, if the contraindications model doesn't want to supply any source attributes to users to view, that's up to their users and up to them. NES EHR still needs to make fields available. So insofar as Konami wants to provide those source attributes, they have the ability to do so. But NES EHR in this third scenario is not responsible for risk management on this model or source attributes related to this model. Okay, next slide. To draw out the analogy just a little bit further and to make clear a couple of other points that we want to make. Essentially, a developer that either produces or authors their own predictive DSI, or if they work with another company to supply a predictive DSI, they can be certified to B11. So too can a developer who chooses not to author, develop, or supply a predictive DSI. They too can be certified to B11. So the certification requirements around B11 do not hinge on whether or not the developer supplies a predictive DSI. Okay, next slide, please. Okay, so just real quick on the actual source attributes here. If you look here on the left, those are the source attributes that should already be available to users for evidence-based decision support interventions. If you go to the Code of Federal Regulations and you look at 170.315A9, you will see the phrase evidence-based decision support intervention, and that has been there since 2012. That was part of the 2014 edition. And ever since the 2014 edition, evidence-based DSIs should have come with, or users of evidence-based DSIs should have access to the bibliographic information, developer of the intervention, funding source, as well as release of the or revision dates of the intervention. These have been on the books since 2014. Users should have access to evidence-based DSI source attributes today. What we added in B11 are the demographic data elements on the right. And as you can see, a close read of this actually would kind of bucket this as a fifth source attribute, not 5 through 13 source attributes, but really the fifth source attribute is, does the intervention use any of the following demographic data as part of the intervention? Because of the way the regulation and interplay between legal is concerned, we needed to kind of spell these out on a line-by-line basis. But a very important way to read this fifth element is, does the evidence-based DSI use race or ethnicity, language, sexual orientation, gender identity, sex, age, or any of the social determinants or health status assessment data included as part of the US CDI? Okay, next slide. Okay, so here's the 9 categories of source attribute information for predictive DSIs now. And as you can see here, really the information that we're trying to cultivate for users in order to determine if the predictive DSI is faves is, how is the DSI developed? What is it supposed to be used for? What evaluative steps have been taken to ensure validity and fairness? And then what are some of the ongoing ongoing maintenance and update activities that we would expect, or that users should expect of this model? Essentially, we tried to cultivate information that would allow users to understand how the model was designed, developed, tested, evaluated, and should be used. So if you go to the next slide, you'll see the detailed breakdown that you find in the Federal Register, in the Code of Federal Regulations today. And again, I readily appreciate how this is a lot. And at first blush, it seems like an incredible amount of information, but I think once you spend some time with it, you'll start to appreciate that we're asking for some fairly general and fairly basic types of information, some of which are the same as evidence-based DSI, like the name and contact information of the intervention developer, but also just basic things like, what is the value that the intervention produces? Is it a number? Is it a range? Is it an evaluation? Is it a recommendation? And then we've got just some general information around the purpose or the intended use of the predictive DSI. Now, I will note that some of the categories there have an asterisk next to them. And some of the more detailed source attributes, notably kind of 23 and 24, as well as 27 and 29, have asterisks. And essentially, these are source attributes that may be indicated as either unavailable or left blank, essentially. Because we did not require developers to externally validate, but we still think that external validation is a good idea, we've got source attribute fields for those processes, but we're not requiring that information be complete or up to date, because we know that that's kind of an extra step and something that the developers' customers may need and want to be involved in. The same with validation of the intervention and fairness of the intervention in local data. Obviously, that would require users to go through a process, not just the developers. So we tried to keep these focused on the things that we knew were well within the control and agency of certified health IT developers. But we still think that this information is really helpful and important to its faves use. And so we think the absence of this information should be a signal unto itself and have requirements for those fields to be supported. Okay, next slide, please. Okay, a few additional kinds of things, kind of turning a semi-step away from the source attributes. There are new capabilities, new functionalities that B11 has that A9 did not have. Those include, for evidence-based decision support interventions, the ability for users to provide feedback, and for a limited set of identified users to be able to have essentially feedback data exported in a computable format. We list there the data that we think would be relevant for an export of feedback data. This is, again, this is a minimum set of data. There could be other data that could be useful for folks trying to do quality improvement on their evidence-based DSIs. So just know that this is a floor. This is the minimum, but maybe not the complete universe of data elements that might be useful. We also have, essentially, we've also established a lot of discussion in the preamble around what an evidence-based DSI is, and we've tried to provide some parameters without providing an actual definition, because we know that this space is quite large, and we tried to direct folks to those evidence-based DSIs that we thought would be most important to provide source attributes for, as well as to provide this feedback functionality for. And you can see there that we talk about evidence-based DSIs that are actively presented to users in clinical workflow to enhance, inform, or influence decision-making related to the care a patient receives. At any rate, we can go to the next slide, please. Okay, so looking at intervention risk management, this was the organizational transparency that we talked about early on. And essentially, we followed and borrowed heavily from the NIST AI risk management framework, which published just before our proposed rule. We worked very closely with NIST to try and ensure that risk management practices, as we envisioned them, would be aligned with all of the feedback that NIST got. And they got an incredible amount of feedback, and I think generally has been highly regarded by pretty much everybody involved in this space. But we know that the NIST AI RMF is not the only risk management framework out there. In fact, there's tons of them. And there are tons of different ways that you can think about risk. But essentially what we ask is that developers analyze potential risks and adverse impacts, take steps to mitigate those risks, and then think about how to implement controls for governance, specifically data governance, so that there is deliberate and express focus on how data are acquired, managed, and used. And then we do have requirements that essentially developers need to apply risk management to all the predictive DSIs that they supply, but they don't need to make that information publicly available. What they need to make publicly available is a summary of risk management and governance practices. And that summary doesn't need to be specific to specific predictive DSIs. It can be at a more general level. And they do need to cover the eight characteristics, to use the NIST turn of phrase, on the left there. Okay, so next slide, please. All right, so we did have a wraparound requirement for assurances and condition and maintenance certification requirement. Essentially what this means is that on an ongoing basis, developers have to review and update source attribute information, as well as update intervention risk management practices, and if necessary, update the summary information that they provide to their ACBs. And this really just recognizes that, essentially we are working with information that's not static. I think probably in the case of a lot of evidence-based DSIs, the information is static, but we know certainly across predictive DSIs, the source attribute information will not be static. And so there is a requirement that developers update source attributes information when they release new versions of models, or when they know that when they're working with clients to externally validate models, or when they're testing models in local data, and the developers are part of that process. Now, obviously, if the developers aren't part of the external validation process or the local testing process, then they're not on the hook to update that information, but they are required to enable their users to update that information. And hence, we've got the modification requirements in B11 for source attributes. All right, next slide. Okay, so on implementation, there's a host of things that need to happen before the end of the year. You can see them listed here. One of them is to update Certified Health IT to support the capabilities of B11. And that is if you have technology that's certified to A9 and you wish to be continued compliant with the base EHR definition, because that definition at this juncture would have A9 expire and have B11 take over at the end of 2024. Also, developers will need to provide summary IRM practice information to their ACBs, and they'll need to keep this information up to date. We haven't talked a lot about it, but B11 is now part of the real-world testing condition and maintenance of certification requirement. So that means if you certify your technology to B11 before the cutoff date, you'll need to include B11 in your real-world testing plans and subsequent results. For providers, obviously they're looking to deploy this technology. So during their 2025 performance period, they should have access to and use of certified technology that's certified to B11, including access to more detailed source attribute information for both evidence-based and predictive DSIs that they use. Next slide. Okay, taking a pivot now to the conditions and maintenance of certification requirements. I'll talk briefly here. There's a lot of really good information on this new condition and maintenance of certification requirement on the ONC website. And I'm sure there will be a lot of future conversations here and in subsequent roundtables. But to lay kind of the foundation, we did implement one of the lingering aspects of the 21st Century Cures Act. One of the things that we telegraphed through the ONC Cures final rule, and something that we proposed in HTI 1. And that is a set of requirements, a set of reporting kind of measures that would provide insight into how certified health IT was operating in the real world, and would be a complement to the developer kind of authored and initiated real world testing plans. Now, the Cures Act actually had, I think, 4 or 5 different dimensions of measurement. That spanned everything from interoperability to security to usability to conformance testing. And I think there were a couple others. We chose to focus initially and primarily on interoperability measures to try and help understand the state of interoperability across certified health IT, and really try to understand if we could get information around how certified technology was being used within the context of interoperability. So next slide, please. Okay, so here are the areas and the specific measurements and the related certification criteria for the kind of interoperability focused measures that we finalized in HTI 1. You can see that we've got individual access to EHI, clinical care information exchange, public health information exchange, and then standards adoption and conformance. Those are kind of the big buckets. And inside of those buckets, we've got specific measures. And these measures are underpinned by some measure specification sheets, which I think we've got a link to in this in a subsequent slide. I think what's really important for you all to look at is whether or not you've got modules that are certified to E1 or G10, B2, or F1. Those are the kind of implicated certification criteria. If your module is not certified to one of those, then the task of developing measures is something that you'll not have to do, and we'll talk a little bit about what that looks like in terms of attestation. But next slide, please. Okay, so again, we did set some thresholds based primarily on instructions from Congress, and trying to translate this notion of not unduly burdening small and startup developers. So we actually created a threshold of at least 50 hospital sites or 500 individual clinician users across a certified product. If you are a developer that does not have 50 hospitals or 500 individual clinician users, you may be exempt from having to report measures. If you don't have modules that are certified to those specified criteria, then you may be exempt. And then if you don't have any users actually using the certified health IT that are associated with the measure, you may be exempt. So developers of certified health IT who do not meet the qualifications above will submit a kind of attestation to indicate that they do not meet the minimum reporting qualifications for a measure. And there will be subsequent instruction on how all that gets done. Next slide, please. All right, so we did stagger the reporting timeline. Rather than have everybody begin reporting across all the measures at the same time, we decided to break this up actually into kind of a 4-year implementation to getting to all, I think, 9 of those measures. And so it's important to note that the reporting frequency and the timeline is at first blush a little complicated, but what it's meant to do is provide some breathing room for development, as well as some breathing room for collection of data and submission of data related to those measures. So I won't go through this in detail, but certainly it's something you'll have some time to familiarize yourself with if you haven't done so already. All right, next slide, please. Okay, here's the resources I mentioned. If it isn't already one of your most visited and favorite web pages in all of the internet, you should go to healthit.gov/HTI-1 and bookmark that. There you'll be able to find a whole host of information and resources, most notably the measure specification sheets. Okay, next slide, please. Okay, and just to kind of reiterate something, you know, I think we did hear a lot of and got a lot of really good feedback during the proposed rule process. And it did lead to us trying to implement this program in a way that would be most palatable. And again, we tried to take a very focused view of how this program could look. Congress wanted us to essentially have reporting measures across 5 different domains. We started with 1 domain, and that's on interoperability. You know, again, we're trying to be responsive to some of the issues and challenges that you all are facing. So please continue to let us know as you start to think about development and as you think about implementation of some of these insights measures. I guess I will note here that the measures can be reused for meeting real-world testing reporting requirements insofar as you include these measures as part of your plan. Okay, next slide. Okay, that's it. Jim, over to you.
Hey, great. Thank you, and good afternoon, everyone. Let's go ahead and start with Chapel HTI-1 features. So because of the change to discontinuing the year-themed editions and establishing a single set of certification criteria, one of the main things that you're going to see different in the Certified Health IT product list, or Chapel, is the removal of certification edition from the search and listing view details screens. We've also added standards to the listing details and some specific indicators for standards and functionality tested that are based on dates that are associated with the rule. So you'll see update needed indicator for any standards or functionality tested where an update is required by a future date. You'll see a requirement met indicator, which means that a requirement has been met before its required date, and requirement not met, which is a requirement was not met by its required date. So we'll look at each one of these individually, starting with the next slide, as we look at the changes to the Chapel search and results screen. And primarily what you're going to notice in the difference between the top screenshot and the bottom is that we did remove the filters associated with certification edition, and we also removed the certification edition column. So anywhere that there were references to certification edition, you won't see those anymore in Chapel. Some people had expressed concerns and wanted to make sure that there was still a way to get to the previous editions, the 2011, 2014, and previous versions of 2015 before Cure's update. And if you go to the next slide, we added a lookup process here where if you do a search in Chapel on any of those listings that are either withdrawn or retired, so it includes all previous editions, and you get a no results found, because by default in Chapel, we only show you the active certificates, the active products. But we did add a section in here that says can't find what you're looking for, and gives you the option to clear your filters to see more. So any of those listings that you're interested in from previous editions can still be found through the Chapel search feature. Next slide, please. So the other big change is in the listing details. And if you look at the screenshot on the right, you'll see that we've added a new attribute for standards about halfway down through the listing details section. And all of the standards that are appropriate and associated with a particular criteria will be listed in this section. There will also be the indicators that I mentioned at the beginning that will display on the right of any of those standards. It would also display in the functionality tested section, depending on whether any of the functionalities tested or standards have any date associated with them, such as meeting a requirement early, or that an update is required by a particular date. And if you roll over those, there is a tooltip that shows you the details behind what must be done to update to the newest standard associated with that. We also, you'll see at the top of every one of the criteria in Chapel now is a link to the certification companion guide, and we'll just make it easy for you to get there and get that information associated with each of these criteria. So those are the main updates you're going to see in Chapel. Just the updates, the new standards are going to show up here, and you'll no longer see the certification edition information. Thank you. We'll turn it over to Ashley.
Hi, thanks, Jim. Hi, I'm Ashley Hain, and I will be reviewing some of the enhancements that we've made to the ONC certification programs, certification companion guides, and test procedures. As of the final rule for HTI 1, we made several updates on March 11th, 2024 to these pages, and we'll be walking you through them. If we could move to the next slide. And those include the accordion updates. We also have a CCG table update, as well as new drop-down features for the test procedures that are dependent on expiration dates and required dates. And if we can move to the next slide. And the accordion updates, we've added several accordions, also for criteria if criteria does not have a applicable accordion, such as privacy and security requirements, it just will not appear for that applicable criteria. We've also removed the resource document in the accordion feature, and that will now be further down and will be included within guidance that's provided later in the criteria. We can move to the next slide, please. In the required update deadlines accordion, we have provided high-level summaries of any major updates that also have required deadlines. If there are no updates and required deadlines, we will not have this accordion appear for some of the criteria. So it's only the ones that are applicable to deadlines. Next slide, please. And for the certification dependencies, this relates to the conditions and maintenance and or design and performance related requirements. It's very criterion specific and will also it's not intended to summarize all of the criteria. Next slide, please. And as mentioned before, we also have a privacy and security requirements accordion. This will only appear if the criteria also includes a privacy and security framework. It lists all of the documentations and some reference links as well. Next slide, please. And for the version history, we historically within the program, we have reset the version history after every major update and rule. So for the 2014 edition, 2015 edition, Cures update, and now for the HTI1 rule effective with the edition list, we've now moved to another new version of version 1. And any major updates in the future for certification criteria for the CCGs or test procedures, that will move or increase the first digit, and then the second digit will move for any minor updates to a certification companion guide or test procedure. And then if we can move to the next slide, please. And for the CCG table updates, we have added a insights header as well as a requires header. And we have also included hyperlinks that can also take you to each individual website that provides more details into all of the requirements that are applicable to the headers. Next slide, please. And then we have a new feature in the test procedures for drop-down selections. So we've structured the test procedures for the any areas that actually have separate requirements that may be based on updated rules. If there's a expires on or a required by date, we have separated them out so you can clearly see the different procedures that you would have to take under the criteria that are changed, and also when you would have to be required to have that capability and test performed. If there are no changes to any of the subparagraph requirements, these expandable sections in the test procedures will not appear. So it's only for major updates, and when there are changes, this will not appear if there is not an update. And then next slide, please. And I ran through that quickly because we want to save a few minutes at the end for questions, for our question and answer portion. Please submit any questions in the Q&A chat feature, and we will try to address them. And I will turn the mic over to Jeff, who may have a question already prepared to respond to in the chat. Thank you.
All right. Thank you, Ashley, and thank you all for sending in some questions. We are trying to answer some of those in the Q&A box, but there are a couple here that we can answer live. So the first one here is going with the NES analogy. If both game cartridges can be seen in the Nintendo store, does that imply stewardship? Parenthetically, both games can integrate with the NES's APIs, and Nintendo wants to show that availability is possible, but only one game was developed collaboratively. So the answer to the question is that the kind of source attribute and intervention risk management requirements would only pertain to the game that was developed collaboratively. We know obviously several developers have app stores, but we don't consider predictive DSIs that are offered through the App Store supplied by, unless unless the developer themselves have gone, have gone to promote a specific predictive DSI that they have collaboratively worked with. So this does, I think there is some fairly clear discussion in the final rule regarding supplied by. We didn't speak specifically to the App Store construct, but simply listing a predictive DSI in a developer's App Store does not mean that that predictive DSI is necessarily supplied by the developer. So just being in the App Store isn't a determinative quality for that. So hopefully that answers that question. Another question is on B11 CCG does not have any security criteria dependencies listed. Is that intentional, or does that CCG need to be updated? The A9 CCG has the privacy and security requirements accordion, but the B11 CCG rather does not. I would say that it was our intention to ensure that the same wraparound requirements for A9 pertained to B11, and that it is a known omission that we may try to correct in the future regarding privacy and security related criteria to B11. I would say, just as a general practice, it would be very smart to consider privacy and security requirements A9 that are pertinent to A9 as something you might want to consider for B11. It's not currently a requirement in HTI1, but it is a known omission that we are taking a very serious look at as we speak. Okay, so let's see here. I just had one disappear on me. Okay, a couple of questions on feedback loops. I just see we've got 3 more questions here, or 3 more minutes rather. What is the expected date range for the feedback report? That is a good question. We do not have requirements around a specified date range for the feedback reports. Certainly one of the data elements in there was feedback, date. But we don't have specifics around date ranges. So consider that a question that you as developers and your customers can hopefully work out. Okay, and then another feedback loop question was on location. Is there a where the intervention was displayed to the end user? Generally speaking, we did not specify how location is expressed or measured. So again, I think if it makes the most sense to indicate that the location be where the intervention was displayed, that makes a lot of sense to me as a plain language and straight reading of the concept of location. But just know that we don't have any specifics around that. So if you run into a question of, is it this location or that location? The answer is going to be yes, because we didn't specify exactly the location. But I think as you think about what kind of feedback data would be helpful, knowing that a CDS fired at a specific location, the more specific you can get, probably the more helpful it would be. But we don't have any specific requirements there. Okay, let's see here. I think we've answered those questions, and I thought there was one more, but I can't see it anymore. So I guess we've got exactly 60 seconds left. So, when will the resource guide for DSI be available? As soon as possible. We are in the closing stages of review So I'm really very optimistic that the resource guide, which will hopefully be both comprehensive and yet comprehensible, will be available as soon as we can get it out. Truly, we would love for it to have been out by now, but at the same time, the review processes do take some time internally. So we're working on that. Obviously, in the meantime, we do have a Health IT feedback and inquiry portal. So feel free to continue to send questions to that we haven't yet got to here. Thank you.
Also, we have our B11 certification companion guide on the website, the B11 CCG. And if you look at some of the clarifications, they answer a lot of questions that people have. So in the meantime, encourage people to take a look at the certification website and look at that B11 CCG for more information as well.
Okay. Thank you all.